So could you outline, please, what the different types of blood cancers are?
Broadly, blood cancers are divided into major groups, and the big groups are leukemia, lymphoma, also myeloma, but we won't talk much about that today. The leukemias are further subdivided into aggressive diseases, which if you're diagnosed you need to be treated immediately because they progress really rapidly, and we call those the acute leukemias. And other leukemias that when you're diagnosed, it's still a serious diagnosis, but your disease is likely to progress relatively slowly. So if you can almost say there's more room for maneuver. So we have chronic and acute, and then they are divided into the types of cells they affect, and the ones that are affecting cells that are part of our responsive immune system, the cells that protect us from infections, for example, they are called lymphocytes, and the diseases are called acute lymphoid and chronic lymphoid leukemia. And then the other ones are all grouped up in a bag which have a strange name called myeloid, and you have acute myeloid and chronic myeloid. And amongst the leukemias, it's acute myeloid and chronic lymphocytic leukemias that are the most common. The lymphomas likewise are divided depending on their cellular origin. One's named after a man who discovered it, and he's called Hodgkin's lymphoma, and quite sensibly the rest are called non-Hodgkin's lymphomas. And in that group, the non-Hodgkin's lymphomas are the most common. And in total, in the UK, there's 37 to 38,000 new diagnoses a year across the whole spectrum.
Okay, so that figure is actually increasing, but would you say that's because there's more better diagnosis?
Yeah, it's increasing for several reasons. We are certainly diagnosing more. So in the case of the chronic lymphocytic leukemia, people quite often get a diagnosis because they're having a blood test for something else. And in the past, those people weren't caught. So yes, that is true. It's becoming more common for that reason. But it's also becoming more common because we're living longer, and a lot of these diseases are, the likelihood of you getting it increases with the older age you become, and so that's another reason. There are some concerns that lifestyle might be affecting the incidence, but that's a lot more controversial.
So I was wondering if you could discuss now the risk factors for children in getting leukemia.
So that's a really interesting question. There are no hard and fast risk factors from the environment. There have been concerns that, for example, living near high power cables might be a cause. Some people still believe that. I personally don't, and I don't think the data is very strong. There may well be complex genetic predisposition, as we call it. Okay. So it may be that some of the complex genes that you inherit from your ancestors may make you more likely or not. But there isn't any strong risk factor that we can remove from the environment. So what we have to do, rather than, it makes it hard to prevent it, so what we have to do is be aware of it, diagnose it, and treat it. And excitingly now, whereas 20 years ago nearly every child dies of that disease, now over 90% of them will survive, and that's really great.
So in the ONS over the summer, they reported that survival rates have trebled over the last 40 years for leukemia. I was wondering if you could discuss any treatments that have contributed to that pleasing statistic.
Well, if we start with the childhood ones, there's no real magic there. The cures that we're achieving there are via what everybody would recognise by the term chemotherapy. But where the progress has been made, and this is true across all the leukemias, is that we have got a lot better at learning how to use different chemotherapies together, and so that they work better together. We've got a lot better at supporting patients through the treatment so that we have less treatment-related deaths. We are diagnosing more early and treating more early, so it's a really complicated thing. But what's changing now is that rather than chemotherapy, more chemotherapy, the fantastic research that my organisation and other organisations support has led to a great deal of biological knowledge about the disease. And we're actually truly now in an era of designer drugs, where we can get drugs that only target the cancer cells. That means that there's no systemic toxicity to the patient, which means that virtually every patient can be treated rather than just those that are fit enough to tolerate chemotherapy. So yes, there have been big improvements. In some diseases it's been dramatic, in other diseases it's been disappointing, but I think in the next 10 years we're going to see some amazing things.
The Christie in Manchester a few weeks ago launched its mobile chemotherapy unit. So we discussed as well about gene therapy. Do you really see those as the future in sustainability?
I would like to see chemotherapy disappear.
Okay.
I think a mobile chemotherapy unit is a fantastic thing, and chemotherapy is here for some years to come, and it works. So let's enjoy that and celebrate that. But chemotherapy is nasty, it's toxic, it has side effects which are hard to manage. But the fact now that we have drugs that we can give patients that actually manage the side effects of chemotherapy, it now means they don't have to come into hospital always to have that chemotherapy, and hence we have these mobile units. And for the quality of life, particularly for older patients who can't travel very well, it's a magnificent thing. It's a really exciting venture. You talked about gene therapy. Gene therapy has proven very, very difficult. I think it will come. There are interesting genetic experiments going on in clinical trials that we're supporting. And interestingly, the gene alterations are not being made in the disease cells, but to make patients' immune cells better able to recognize the cancer and therefore eradicate it. So yes, I think in the next 4 or 5 years we'll start to see trials of that nature coming out with more frequency. But then there's also the magic bullet drugs. So there's something in between the two, which are still drugs, but are these ones that are targeted just at the cancer cells. So the armory that we now have to tackle these diseases is much more varied and sophisticated than it was 10 years ago. And I imagine in 10 years' time it'll be even more sophisticated.
One of the things the charity that you work for, Leukemia and Lymphoma Research, does is all the funds go towards research projects. Would you like to tell us how much money goes into that?
Well, last year, as a charity, we made our biggest ever commitment in a single year, and we committed just over £32 million in a year. In the Manchester area, we and Greater Manchester and Manchester combined, we have £3.7 million committed to research at the moment, and that includes some very sophisticated laboratory studies trying to understand the disease, find these targets we can make the magic bullets to, and right through to cutting edge clinical trials which the world is looking in on and are excited about. So Manchester's an exciting place for us.
Wondering if you could discuss now past trials or research that has proved a great success for Manchester.
There's a trial that's just finished that has been looking at using something called a PET scan, where you can actually visualize the tumor inside the patient, and using that to decide how patients should be treated. This is what's called stratified medicine. And when all patients get chemotherapy up front, but some patients respond better to that than others, and because not all patients respond well, we have to use radiotherapy as well. But what this trial is doing is trying to find those patients that don't need the radiotherapy. That trial's finished, it will be published soon. We can't foretell the results because the analysis isn't finished, but I know it looks exciting. And then there's a new trial that the same group is starting in a different group of patients. So some patients get the Hodgkin's lymphoma, which these trials are in, later in life, and that intense chemotherapy in combination with radiotherapy they can't tolerate. And for that group of patients we need one of these magic bullet therapies, and we have one. We're going to try it, and it'll be exciting.